And hopefully that's working. Okay, we have participants joining us. And, aha, that's not going to work. I have that on the wrong screen. Okay, now we're right. Okay. We are live on Facebook right now. Give everybody on Facebook a minute to let them know that we're here. And I want to welcome everybody this evening to this stop on the HCMA's Bighearted Warriors Unite Tour. Today we are visiting University of Texas Southwestern in Dallas, Texas, and we're going to get our program started in just a few minutes. I wanted to give some housekeeping tips this evening. And if you are watching us on Facebook, I'm going to be putting a link in. If you would like to join us in the Zoom room, you can do so by registering at any time during the session. If you are watching through Facebook, we really love having you with us, but we can't take questions from Facebook. It just is very logistically difficult. So we ask that you join the Zoom room. If you have any specific questions, you can ask them at the end of the session or in between sessions and speakers. So that's how that's going to work. To those of you who are in the Zoom room with us, I'm going to let you know how it's going to work in here. In the Zoom room, you have a question and answer tab that you can ask questions, and throughout the session we may answer them in writing, or we may wait till a break and we may ask it for the audience. You do not have to have your name attached to your question. That's fine. At the end of the session, when we're done with all of the Q&A, we will stop streaming on Facebook, and if somebody wants to ask a verbal question or make a verbal comment, you can raise your hand using the tool and I will unmute your microphone and you can join us with a verbal question at the end. We are not letting that stream through on Facebook because we want to maintain your privacy, and you didn't necessarily sign up to be internet famous with your question. So that's how that's going to work for the rest of the evening. Okay, so that being said, I am going to come back to the Brady Bunch view. Everything here looks like it's working and we're starting to populate. If you're watching this any other day than May 13th at about 7 p.m. Eastern time, 6 p.m. Central, then you're not watching us live. You're watching a reboot of this, which will live on our YouTube channel and our Facebook channel. So if you're watching after the event is over, post your questions below. The HCMA staff will try to respond to them at a later date. So with that said, the housekeeping done, I'm going to turn the microphone over to Aslan Turer, the director of the, or co-director of the HCM program. And he has some announcements and some introductions to make. And I hand it off to you, Aslan. Thank you for being here.
Well, Lisa, thanks for the opportunity to reach out to everybody today. We had an amazing experience a couple of years ago when we did this in person at our university hospital. It was, I think, very well received by patients, and we really enjoyed it. We met a lot of new friends and patients that day. We learned a lot from that experience, and we appreciate the opportunity to do this in a different medium that'll be saved, and people can watch this again, and hopefully we can reach out to some new patients and friends tonight. So we started a little late, so I'm going to just quickly go over the agenda for tonight. Lisa will start us off. Then we'll come back, and Mark Link, who co-directs the program with me, who is our electrophysiologist extraordinaire, content expert here on the guidelines, and written innumerable articles on HCM. We'll talk about atrial fibrillation, a common coincidental condition with hypertrophic cardiomyopathy. And then I'll talk about some lifestyle issues with hypertrophic cardiomyopathy. And then Shivani Patel, who is one of our OBGYN and maternal fetal medicine experts who deals with a lot of high-risk patients and who has been involved with a study which many participants may have been actually involved with pregnancy and HCM. We designed with Lisa that questionnaire, and we got some incredible data, and We're in the process of analyzing all that. She's going to talk about HCM and pregnancy. And then Markey McNutt, who had a very well received lecture a couple of years ago at our in-person HCMA talk, will again discuss family screening and genetics and hypertrophic cardiomyopathy. And at the end, I'd like to introduce Dr. Wan, who's a new member of our team, and he'll say a few words to meet the gang. So I guess without further ado, I'll send it back to Lisa to talk about some issues, and then she'll kick it back to Mark after that.
Awesome. Okay, so I am going to be a bit transparent here. My PowerPoint is on my computer at home. So we're going to talk through a couple of issues tonight, and I don't have slides on some of the things I'm going to talk about because I went home from the office and I sat down at the computer and we had a power outage for the second time today. And my electric didn't seem stable in New Jersey today. So, or in that part of Jersey. So I came back to the office. So I apologize if there's things that would have been better addressed with a slide that I just don't have today. So you should be seeing my screen now, right? There we go. Okay. So first of all, it would be, there we go. It would be appropriate at this point to thank our sponsors. And I do have to apologize to Myocardia Bristol Myers Squibb for having the wrong logo on this particular thank you slide, but the good ones on the computer that crashed at home. So my apologies. Boston Scientific, Cytokinetics, and Invitae. And we have some new partnerships to announce later that, while not monetary, all of them are an amazing advance for us at the HCMA and partnerships that we'll be discussing a little bit later. So I'm going to start off really a little different tonight. I just want to take a dive into the entire concept of centers of excellence. And in that, when somebody's new to the HCMA and they hear everybody talking in this code of, well, you got to go to a COE, you got to go to a COE, people don't understand the meaning behind it all the time because it's not a concept that they're used to. So I want to take a few minutes and explain that the HCMA Recognized Center of Excellence program has been established over about the past 18 years. It started as just referrals to the highest volume programs, particularly for surgery early on, or people who had extreme knowledge or research interest in treating HCM. And then we started to build out different models of care. We stole tips from other disease states, what works, what collaborative efforts work best to suit a patient's needs. We've created an evaluation process, and this is an ever evolving process. And there's going to be another twist coming up soon too. We're going to be onboarding some new committees. I'll tell you about that a little bit later. As of today, we have 42 HCMA recognized centers of excellence. All the dots aren't the right color on this map. My apologies to Rochester Regional and Rochester, New York. They are officially a red dot now. So I'm sorry about that. And there is another pink dot over here because we have another program in Tennessee that is under evaluation at this time. So we are up to 42 programs. We estimate in these programs at this time, there are approximately 45 to 50,000 individuals with hypertrophic cardiomyopathy being cared for in this care model. Interestingly, insurance databases indicate that there are only about 120,000 HCM patients being treated in the entire United States, which tells you that the majority of which are being treated at HCMA recognized centers of excellence. And we got to get the rest of them over there eventually, hopefully too. So, and then we have to go out and find the other 700,000 of us that might be out in the world in the United States. And then of course we have to think internationally. I'll talk a little bit about that probably at the next session. So that's the Center of Excellence structure, and meet your Center of Excellence team. Okay, HCM is serious. Sometimes our slides have to be a little lighter. So what does a center do? You have a hocomologist or hocomologists, and these are people who specialize in not only an area of cardiology, typically imaging or heart failure, but sometimes electrophysiology or interventional cardiology. They work as a collaborative team. They do case management together. They have discussions about your case with an entire team. And each person with HCM is put through a step system of imaging and evaluation and testing and genetics. And we look at a lot of different variables. And we also know that these are people who have normal lives too. There are women who get pregnant and have babies. There are people who have knee replacement surgery. So there's a lot of different specialty care processes involved with your HCM care, but your Center of Excellence program can manage them best in their silos, if you will. But then the important part is that they all go back to the HCMologist for that continuity of cares to make sure that something doesn't get missed along the way. This care model has proven out to be incredibly successful, so much so that the American College of Cardiology and the American Heart Association, in their new guidelines issued in December 2020, indicate that the best care model for HCM is what they call a comprehensive HCM COE, which basically is the definition of a hypertrophic cardiomyopathy association recognized center of excellence, just different words. So we are honored that they recognize that this is in fact the best care model. But you'll see that there are other programs that may not go from, let's say, pre-pregnancy planning through to end-stage disease management, transplant, or natural death from other issues. They may have good diagnostics, they may have the ability to do ICDs, but they don't do transplant, they don't do myectomy surgery. They would be a primary HCM center, and there's a role for them too, and many of the HCMA recognized centers do have a primary model, and they refer off to high volume surgeons and transplant programs when care gets too evolved. And your primary cardiologist, there's always a role for somebody in your backyard who knows you and can communicate with your HCM team. Excuse me. So from the patient perspective, we know based on surveys and 25 years of experience, the patients treated in an HCMA COE model get better care, have a more supportive relationship with their team, feel physically and emotionally supported, far superior to that being when they were treated outside of the center. We know that outcomes from invasive procedures have lower complication rates and outcomes are better, and they have the ability to participate in clinical trials, which are critically important as there are 2 major trials going on right now and a third about to embark. Actually, a third and a fourth, and maybe even a fifth. I got lots of stuff going on here, guys. So I'm sorry, that's a duplicate slide. So I'm going to pause here and just talk about the importance, believe it or not, of social media. Now I know Facebook can be contentious for some people, but for our purposes to communicate among our patient population, it is critically important. And the models that we have are moderated communities with about 7 or 8 moderators from different time zones, literally around the globe, so that no question ever goes without being answered within a few hours from a trained moderator. And obviously members of the community are there to support as well. We're always recruiting for new moderators, and if you are interested in such a position, please contact us. You're going to see in the next couple of weeks the launching of other Facebook groups attached to the HCMA's main page. Specifically, HCM Sweden is coming on board. So this is going to be in our international programming. We're also working with our partners in Italy to get their patients engaged as well. And we have outreach efforts with other countries that we will build out over the next 24 months. So we ain't just America anymore, or North America, I should say, because our Canadians are always here too. So we've got that. We have our online live discussion groups where you can come and communicate. We used to call them support groups. They're really more discussion groups where you can get support, but you can also just have a robust discussion with your peers about issues that are of concern to you. You're getting an ICD, you're not sure what to expect, go talk to your peers. They can help you through the process. You might be getting an AFib ablation, a myectomy, you're heading down the transplant pathway. We have discussion groups in all of these areas. So please sign up and join them. I do have another little thing I'm going to show you in a second, but we'll get there. For those of you who are following podcasts, Tales from the Heart is the podcast from the HCMA. Tomorrow I will be speaking with Marty Marin at 11 a.m. Eastern time, and we are going to be talking about medical management of HCM, the current drugs that are available, and what's on the horizon. So we're going to look at the tried and true, and we're going to also start discussing in a different way, a little bit more casual way, what the role of new therapeutics like mavacamten from BMS might bring, or the cytokinetics Redwood study drug, or another company called Embryo who's working on a new drug for non-obstructed HCM. So we're going to talk about that tomorrow. And you can pick up the podcast from our Podbean site or anywhere on Facebook. And if you're in the New Jersey area, it's not too late to call Julie tomorrow and tell her you want to come to the HCMA office to share your story on Saturday, May 13th, May what day is that? 15th, when we will be turning this into a production studio and recording new segments for our new website. I'll talk about that in just a second. So part of this slide disappeared, but this is the HCMA's new committee structure. We will be onboarding committees over the next about 12 months. We're not doing them all at once. But earlier I talked about Center of Excellence processing and the evolution of the Center of Excellence process. We're going to form an HCMA COE review committee where there will be patients, healthcare providers, hospital administrators invited to serve on the committee to help establish the best, most rigorous, patient-safe review models for centers as they progress. We go through a lot of work onboarding them, but staff changes, administrations change. We have to make sure that our centers of excellence are meeting the highest standards possible. And we're going to put together a committee to help do that. There'll be a call for applications for the committee. There will be a select number of spots. And we do have specific makeups of each committee that we're looking to fill. Obviously, we want people from all points of view, so all stakeholders will have a voice. And the committees will report to the board will report back to the membership, and we'll tell you what we're going to be doing. So really excited about that. We've got legislative advocacy initiatives coming up, and we have some amazing new partnerships. So there's going to be another slide. It's going to look somewhat like this. The HCMA is going to be embarking upon a formalized way of doing what I'm going to explain. But right now we have alliances and partnerships with a number of different organizations in which they have now come to the table and they know they need to know about HCM. And we are working with each and every one of these organizations to ensure that the patient's voice is heard in all of their efforts to educate and outreach about HCM. So I'm very happy to announce formally that the AHA and the American Heart Association and the HCMA have entered into a partnership agreement, and we will be creating co-branded materials and a couple of other projects that you'll see coming out soon. The American College of Cardiology and us are working together to put together a patient forum to understand the patient journey better. And I am working with them to help develop medical education instruments as well. We are working with the Heart Failure Society, and we will be working in a partnership on a number of different initiatives there. Specifically, when you become a member of the HCMA, you will also become a member of the Heart Failure Society. So you'll be able to keep up on things from all different points of view now and have your voices heard in a larger and broader way, not only within HCM, but the broader heart failure community. In addition to that, we're working with Women Heart, and we're really happy about that one. We're going to be working on messaging relating to the delay in diagnosis, specifically in women. We're working with the American Society of Echocardiography to help improve echo quality throughout the country. All of these relationships, along with a new initiative called the Global Heart Hub, are truly bringing the HCM community together in ways we've never done before. And the HCMA is right at the center of all of this, working with our partners to ensure that the information that's going out is adequate, understandable, meeting the needs of the patient community and the payer community. We're going to start engaging the payers. So insurance companies and CMS, and going after that with some hopefully economic modeling as to why HCM is something they should be concerned with. On that note, and unfortunately I don't have slides on this, there's a review from an organization called ICER, that is the Institute for Clinical and Economic Review. They are currently evaluating mavacamten and its cost effectiveness, or what the cost should be, I should say, to the market. So this is a several month process. A couple of weeks ago, I asked you to submit a survey. There was a scoping document. There's a little bit of a problem with that right now. Some of the people who submitted their comments didn't get put into the final document. So we're tracking down where their comments went. But we are working very closely with ICER to ensure that when they look at pricing of drugs, the first labeled indication drug we're hoping for in HCM, if the FDA approves it, we want to make sure it's priced appropriately. We can't get gouged. They have to understand the financial burdens on HCM families and what we have to spend. We have to get payers to understand its value. And we have to make sure that it stays competitive enough that drug companies want to come back and do more work in the HCM space because it's a good market. Okay, let's be real. But we're all in this together, and we have to be partners, especially in the financial aspect of making sure that not only do we have a good drug, but it's accessible and available to those who need it. So there will be opportunities for you to comment further in that process. I would encourage you to visit the ICER website, and you can see everything they've done on HCM. You can read the HCMA's public comment on the drafting document, and you can see where our concerns are and what we're optimistic about. So big stuff going on in that space. If you have not watched the PFDD yet or seen the Voice of the Patient report, I encourage you to go do that. It's highly, I don't know what just happened there. I'm back. It's highly informative on the burden of disease. We will be doing additional surveying and modeling about the financial burden of HCM, as well as the diagnostic journey in HCM. This PFDD is focused on burden of disease and therapies. So we have to add the diagnostic journey and the economic modeling. But they're really great videos to watch, and it's really an informative discussion. So I would encourage you to all go do that. And you can read the report too. What is going on with my PowerPoint? It's locked. I don't know what's happening. There we go. I wanted to give a shout out to all of our partners in the HCM community, our Center of Excellence partners, our partners at UT Southwestern. A special thank to Aslan for being here tonight and for being a real warrior. We'll discuss that later. To the staff, to the board, and to Valerie Ventry, who is our Center of Excellence coordinator. This is her last public appearance on behalf of the HCMA as she moves on into the next phase of her life. We will be announcing her replacement shortly, but we wanted to thank Valerie for her time and her service. It's been wonderful having her here. And of course, thank you to Brandy, my donor, for without whom I would not be here at all. So I'm going to hand it back over to Mark, and we will hear about atrial fibrillation, one of my most unfavorite topics, but most important topic to discuss. Mark, you're on mute. It had to happen to somebody. It was you. Still on mute.
Mute.
There you go.
Yeah, the problem was I shared my screen, it covered my mute button.
It happens to the best of us.
This one. Share. Okay, now can you see my screen?
We can.
Great. So I want to thank the HCMA and Lisa especially for putting this together. The HCMA has been a phenomenal foundation for our patients and truly an example of a disease-specific foundation that benefits all people. And when she started this, it was, hardly anyone knew about HCM, and now it's becoming a much better known disease, and certainly part because of the HCMA. My role in HCM is that I'm an electrophysiologist, so I am an electrician, as I tell my patients, and so my role is to deal with the electricity of the heart and let Dr. Turer deal with the muscles of the heart. So I'm going to talk to you about AFib, and specifically AFib as it relates to HCM patients. I'm going to start with a patient of mine. He's Mr. HS, 56-year-old male. HCM was diagnosed 6 years ago. He had a sub-Q ICD placed because of massive hypertrophy and non-sustained ventricular tachycardia. His sub-Q ICD documents that he's having AFib. And these aren't perfect, so we put a loop monitor on him, and it shows he's in AFib 3% of the time. And he's mildly symptomatic. He doesn't crash and burn when he's in AFib, as, to be honest, a lot of my HCM patient said, but he knows he's in it and doesn't particularly like it, but can still work and exercise. AFib is relatively common in patients with HCM. If you look at this data from 2001, about 5 or 6% of individuals under the age of 30 with hypertrophic cardiomyopathy have AFib. And to see someone under the age of 30 with AFib is almost unheard of unless they have something else wrong with their heart, such as valve disease, hypertrophic cardiomyopathy, congenital heart disease. And as we age, more patients with HCM will get AFib. Now, to put this in perspective, if you look at a normal 70-year-old, or 70, I shouldn't say normal, 70-year-old without hypertrophic cardiomyopathy, they're going to have AFib 5 to 7% of the time. So that a patient with HCM has about a 4 to 5-fold risk of getting AFib over their lifetime. And we know that AFib is associated with a poorer outcome. And it's very important to look at the word associated. This does not mean causal. It doesn't mean that AFib causes the problem. It's associated with it. And it may just be a marker for worse HCM, but clearly it's associated with a poorer outcome. And it's also associated with heart failure admissions. If you have HCM and AFib, you are far more likely to get admitted with heart failure than if you have HCM without AFib. And it's more likely, it's again associated with stroke. This probably is more causal because of what we know about the mechanisms of stroke in patients with AFib. Now, the rest of the talk, I'm going to be talking about clinical practice guidelines and how to treat patients. And this is codified in the 2020 AHA-ACC guideline, which was an update from 2011. And there's been a lot of changes since 2011, a tremendous amount of change with regards to AFib. When you think of AFib treatment, you really have to think of the two pillars of AFib. One is anticoagulation, and that's to prevent strokes. And the other is, do you strive to keep you in sinus rhythm or just keep you rate controlled? Now, anticoagulation. In the last 10 years, there's been a number of clinical trials with direct acting anticoagulants. Now, the historical drug we used was warfarin. Warfarin was actually, discovered 70, 80 years ago when cows in Wisconsin started bleeding out. And what they found is these cows in Wisconsin were on a field that had foxglove, and they were eating the foxglove. And foxglove is where warfarin is made from. And it's kind of an odd agent. It inhibits a protein, but it's a very effective anticoagulant. And if it's well managed, that is, it can really be a very effective drug. So what are the pluses and minuses of warfarin versus DOACs? The pluses of warfarin is the long history of using it. You can tell if a patient's taking it by checking INRs. There is a reversible agent that's readily available at every hospital. The problem is there's dietary issues. You can't eat vitamin K containing food because it'll mess up the INR. And it's difficult to keep the INR in range in a lot of patients for this dietary. It's affected by antibiotics, it's affected by a lot of other drugs. So it's not a perfect drug. When you take the DOACs are more of a traditional drug. They don't interfere with protein synthesis as warfarin does. They are active when they are in the bloodstream and not active when they're out of the bloodstream. So again, these are more normal type drugs. They have to be taken every day, and some of them have to be taken twice a day. There's no dietary issues with these agents. You can eat whatever you want. It's not going to affect it. But they're not perfect agents either. They're expensive. The reversal agents, although they exist, aren't readily available because they're so expensive. And then you have this. All of you who watch TV will see these class action lawsuits for these newer agents. And the reason you see these for these newer agents is these are all on patent. So they're all owned by one company. And so you can sue the company if you have bleeding on these agents. But that's how they work. They're blood thinners. They're going to cause bleeding. The reason you can't sue warfarin is because warfarin's been generic for so long that there's no one company that makes it. And so you'll never see a class action lawsuit for warfarin. But all the clinical trials have shown that these newer agents are actually safer than warfarin in terms of bleeding and likely and more effective. So they really, in my mind, should be the preferred agent if a person can afford them. It's very important that aspirin is not an anticoagulant. It's an antiplatelet agent. It's useful for coronary disease, but it should play no role in AFib. It really doesn't prevent strokes in AFib. So don't think of aspirin as an anticoagulant. Now here's the big question. Do we go for a rate or rhythm control strategy? Now, a rate control strategy means you don't do anything to try to maintain the normal rhythm. You just let people have AFib and then control the heart rate with beta blockers and calcium channel blockers. A rhythm control strategy is where you decide that you don't like being in AFib and therefore you want to do something to maintain normal rhythm. Now, the choice is largely driven by symptoms, and in general, most HCM patients really hate being in AFib. And so in general, the more severe the symptoms are, the more you're going to push for a rhythm control strategy. Here are our antiarrhythmics that we can use in HCM. And this is from, again, the 2000 guidelines. Disopyramide has only modest efficacy, but it's also used for heart failure. So it's often an agent we will use first, but it really doesn't work that well. Flecainide and propafenone, although they're very effective drugs, especially in non-hypertrophs and people without heart disease, they're not generally recommended because the fear of a proarrhythmia, that is, it's going to make things worse, with the exception that they could be used in someone that has an ICD. Sotalol, modest efficacy, has a lot of fatigue and bradycardia, but certainly is reasonable to use. Dofetilide, also modest efficacy, reasonable to use. Dronedarone, low efficacy, don't know how reasonable that is to use. And amiodarone is probably our best agent for, I shouldn't say best, our most likely agent to maintain normal rhythm, but it has a lot of long-term issues, such as liver toxicity, lung toxicity, thyroid toxicity. And for that reason, it's not a preferred agent in our young patients with HCM. So you can see that there's no great antiarrhythmic drug here. Which brings up ablation. And ablation is something that is relatively new, really has made its presence in the last 10, 12 years. Now, the theory behind ablation, this has actually been experimentally shown, is that the problem with AFib begins in the pulmonary veins. The pulmonary veins are what drain the blood from the veins into the left atrium. And what happens is you have got this muscular sleeves, this left atrial tissue that is up inside the veins where it shouldn't be. And when it's there, it gets very irritable and can start to fire rapidly, and that just degenerates into AFib. And so that's why the goal in AFib, and this is, if you'd have told me 20 years ago we'd be ablating AFib, I'd say you're completely nuts. It's a completely chaotic rhythm. There's no way you can ablate it. I'm going to show you here, this is the left atrium. This is a map of the left atrium pre-ablation. Here's the veins that are coming out. And notice, and then the blue purple is high voltage. So that's muscle cells. That's very healthy. Notice how deep into the veins this goes. And the red is less healthy. But it goes all the way out here. And it's these muscle cells that are in these veins that cause the problem. Now, one of the ways that you can ablate these, get rid of this muscle tissue, is a cryoballoon. And one of the ways is heat. I'm just showing you a cryoballoon here. So what you do with this balloon is go into the left atrium, blow up the balloon, occlude the pulmonary vein. You have to do it to each of the pulmonary veins, and then you freeze. And you freeze down to a negative 50 degrees centigrade, so it's very cold. And when you freeze down to that temperature, it kills the cells that are at the ostium of the veins, and therefore it eliminates that electrical connection to the veins. And this is an after picture. So this is a before picture. And notice how afterwards this gray is all scarred, that you've now created a nice, clean, homogeneous line that has knocked out that muscular tissue that was in the vein. And this has an efficacy of probably 60 to 80%. It's more likely to be efficacious when it's done early in the course of AFib. If it's done after patients have been in AFib for 5 to 10 years or persistent AFib, it's less likely to be effective. So there's been a move based on a number of different clinical trials that have come out over the last 2-3 years that trying to maintain AFib early on is preferable to waiting years and years before you try to maintain sinus rhythm. So finally, we're going to come back to Mr. HS. He's mildly symptomatic. He's considering an ablation. He doesn't really want antiarrhythmic drugs because of all the problems with them. So he's still thinking about an ablation. When it came to anticoagulation, initially he was very, very hesitant, as would be normal for a lot of people to be hesitant to go on blood thinners, which do have risk. But when considering, his family, his wife and his kids, and that his risk of stroke, after consideration of all that, he went on a blood thinner and is quite happy living on his blood thinner and beta blockers, seeing me twice a year. So with that, I will turn it back to Lisa. I will unshare my screen, and I'll look forward to questions after we're done here.
Anybody has any questions at this point, they're welcome to put them in the Q&A box. And there is one there right now, and I'm going to just attack this one right away because it's a very hot topic this month on the HCMA Facebook page. How many ablations or too many ablations? How many bites of the apple do you get here?
Yeah, that's a very good question. And the question has more to do with chances of success than danger. There is no increased risk of repeat ablations. They're the same risk as the first one. So the risk does not go up with the more ablations you have, but the benefit drops. If you're still having AFib after 3 or 4 or 5 ablations, it's not so likely that the 6th one is going to fix you. So it really is far more about futility than about risk.
Okay, so I'm hoping this person came a little bit late, and that's why they're asking this question. But the question on the table is, what is AFib?
Yeah, AFib is an chaotic, irregular, you feel palpitations, you feel your heart going haywire and crazy. And it's because it's very, very irregular and erratic. And it's an electrical problem of the upper chambers.
Okay. Carolyn, I'm going to tell you that we're not taking questions by hand raise until the end of the session. For now, you'll be able to use the Q&A feature at the bottom of your browser bar. So I'm going to lower your hand and you can write in your question, or you can hold it till the end. So we have another question, and then I'm going to make that the last question, and we're going to move on to our next talk. And the next question is, would you choose would you choose a myectomy or an ablation? And what's the difference? So
yeah, this is unfortunate that ablation just means killing tissue. And so an alcohol septal ablation is directed towards killing tissue in the septum, and actually is not the same as an AFib ablation, which is killing tissue in the left atrium. One is for AFib, that's the AFib ablation, and the alcohol septal ablation was for the septum. And I've argued that they should have to change their name because we had it first. Ablation for arrhythmias was coined far before alcohol septal ablation, but they won't do it.
I don't think they're giving up on naming it right now.
No, I tried.
It was a good try. We appreciate that. It is confusing here at the HCMA because they'll call up and say, I had an ablation. What kind? I don't know. I was asleep. That's a common answer.
Yeah. No, I actually had to review a paper about alcohol septal ablation 12 years ago, and I pushed really hard to have them change the abbreviation, and they refused, and the editors allowed them to use it.
Okay. Nice try. Thank you anyway. Okay. Bill Keith, how are you doing? If you have constant atrial fibrillation with mild symptoms and are told there is nothing to be done to eliminate it, are you at a longer term risk? So if you're, I'm guessing this would probably be a low rate AFib.
Yeah. There's certainly some controversy about this issue. It's clear that if you have symptoms, you should go for a rhythm control strategy. What's not as clear is, does getting rid of AFib or ablating AFib improve mortality? Does it make you live longer? A big trial called Cabana was published last year and had somewhat mixed results on that question, to be perfectly honest. And so currently, it's not a standard indication to do an ablation, an AFib ablation, because you want to live longer. There may be some tantalizing evidence that you may want to consider, but it's certainly not a standard indication.
So the whole concept in the new guidelines document of shared decision-making is critically important in HCM, because this isn't you must, it's you can. And then you have to balance your risks as an individual and what your expectations are of the procedure. Would that be fair?
Yeah, you mentioned that the shared decision making, that was a huge shift in the guideline document from previous guidelines. And that's a very, very good shift. And it really played out in the decision for defibrillators, but it's very, very important in every decision. And it's very important in AFib management. There are risks and benefits to an ablation, and whether the risk outweighs the benefit is a personal decision.
I hear you. I'm going to let you take a seat for a little while, and I'm going to bring up Aslan to talk to us today about, what is our topic today, Aslan? Now I'm forgetting everything as we go forward here.
I just want to talk about some lifestyle issues.
Very important issues. So why don't you share your screen and take it away, and we'll let you educate us. Did that show up there? Not yet. Technology is just our friend today. Julie can't get back on from our staff, so I told her she had the rest of the night off.
That show up?
That showed up. It's all you. Thanks.
And let me just kind of dovetail on what you guys had just said about the the guidelines and a shift in terms of patient-centered decision making, because to me it makes visiting a COE all that more important, because I have gradually shifted from being I studied this and this is not a hard and fast rule space. We lack a lot of data, and there's so much interpersonal variability in cases that it really goes to, I feel like I'm more of a counselor, having seen things and helping people make decisions rather than, reading it's about having seen a lot of things and talking to patients about individual risks. And those things I think are just far better handled in a COE, rather than having, somebody who has one or two people that they might see over the course of their whole career. So anyway, that was a monumental shift sort of in terms of the guidelines. Well, I'm very happy to be here tonight to talk about some lifestyle modifications. And so I entitled my talk, Eat Wisely, Drink More Water, and Be Merry. So to me, lifestyle modification is about patient empowerment. There are a lot of things the patient will come to our clinic, and we prescribe medications and or procedures. But how people handle the other 99% of their life is more important or just as important on the medications that we prescribe. And it's about controlling their day-to-day activities and giving a sense of control back to the patient. I got interested in this area when Lisa and I wrote a chapter in Shivani Naidu's book on hypertrophic cardiomyopathy. And there's not a lot of evidence here, but it really got me thinking about this area. And I was also struck that I had a number of patients who were very symptomatic from hypertrophic cardiomyopathy, and we almost pulled the trigger in a couple of cases in sending people to surgery. And they made some lifestyle changes, and I'll talk about it, but they lost some weight and felt a ton better. And it not only made me recognize for that one patient that, or those particular patients, what may be driving a lot of their symptoms, but also more generally made me think that there's a lot of opportunity for patients to take control of where their disease process is with these interventions. Something fascinating, we take for granted, I think, as practitioners, that we see people with postprandial angina. In other words, people who come into clinic and they have terrible, what they think is reflux. And many practitioners out in the community don't know about this, and the patients think it's just something that they have. And so many people have been so relieved and to feel like somebody's heard them and understand, put this in context, that this is something very common in hypertrophic cardiomyopathy. They feel like, oh my gosh, so I finally have an explanation for these symptoms. So one important lifestyle thing in hypertrophic cardiomyopathy is I counsel people about postprandial symptoms. They're actually pretty common. I think about half the people have them. And it's a sensation often of chest discomfort or shortness of breath, and sometimes palpitations and increase in just heart flutters that occur after eating. Many patients will have obstruction, but that's not always the case. And it typically happens after large meals. And anecdotally, it seems to happen after high carb meals, many patients will tell us. And this is a perfect forum for people to sort of discuss their own symptoms and for us to kind of get a better handle on what exactly the best kind of dietary intervention would be. It's something, this is kind of information that's better crowdsourced than anything else. But these are just kind of the observations. So what is the cause of this? This has actually been worked out. It's really, there was a very interesting paper that was published a number of years ago out of Mayo in Arizona. And what they did was took patients who were fasting, and then after they ate a big meal, and they did echoes and patients who did or didn't have postprandial symptoms. So the long and the short of this is when patients with hypertrophic cardiomyopathy, particularly with obstruction, eat, they get dilation of the blood vessels to the gut. And this drops the systemic vascular resistance, or the resistance in the blood vessels, particularly in the gut, and drops the systemic blood pressure. And then it makes it easier for the heart to contract, and this hypercontractility causes an increase in left ventricular outflow tract obstruction. This hypercontractility, where the heart's just pumping excessively hard because it's really easy to eject blood, kick blood out of the ventricle, causes more obstruction. This is exactly the opposite of what beta blockers, calcium channel blockers, and myosin inhibitors do. Simplistically, I tell people that you know how your mom told you not to eat a bunch of eat and then jump into the pool because you're going to get a cramp? I kind of tell them it's something like that. It's a little bit more complicated, but it helps people kind of visualize that this is something that's related to eating, shunting blood to their guts, and then something that affects the muscle, just like your mom told you with swimming. This may not be the whole, the whole explanation, because some people with non-obstructive HCM will feel this. So whether there's a stealing phenomenon of blood to the heart or something else hasn't been explained. But we think that when you eat, you get some release. We know of a lot of gut hormones, and some of them may be preferentially secreted or released in response to, for example, carbohydrates. And that might be the cause of this. We talk about staying hydrated, and why is that? We know patients with hypertrophic cardiomyopathy feel worse when they get dehydrated. It's why we are carefully, when we usually try to avoid diuretics, and when we add them, we're very careful. And the reason is because if this is your heart with hypertrophic cardiomyopathy, when you when you're dehydrated, your ventricle is a little smaller. And so the distance between the thickened heart muscle here and the mitral valve is shorter, and you obstruct more. That increased obstruction causes more symptoms. Weight loss. I've come to appreciate how important this is over the last several years. And a lot of this is self-inflicted. Many patients with hypertrophic cardiomyopathy were instructed to avoid exercise for a long time, and for many been continued to been told that. Physiology is complicated here, and there is no one best diet. It's not like with coronary disease, where the Mediterranean diet might be something we suggest, or a low-fat, low cholesterol diet. The physiology is complicated. We don't want people to get too dehydrated. If you go to a ketogenic diet, maybe that's the best thing because you avoid carbs and you don't have as much shunting of blood like we talked about. But people who are on a low carb diet tend to get dehydrated, and that can cause more obstruction. Some of these diets avoid salt, but many people with hypertrophic cardiomyopathy feel better when they have more salt. So it's not easy to know exactly a priori what the best weight loss and diet would be. But we do know that being overweight has been associated with increase in wall thickness and more likely to become symptomatic. I also tell patients, and this is part of my life in the cath lab, I introduced the concept of cardiac index, and it's a little out there, but the cardiac output, or how much, is really a measure of how much blood your heart squeezes per minute. The cardiac index is that number of how much blood your heart pumps per minute, but relative to your body's surface area. So it accounts for weight and size differences. And the cardiac index is a key measure that we use to understand if somebody's heart is functioning well enough to provide their body with enough blood and oxygen for those, to do activity or, go up a flight of stairs. So this cardiac index is a key measure. In hypertrophic cardiomyopathy, because the walls are thick and the ventricular, the volume of the blood that's held by the heart is relatively constrained, and we know that the ability to fill the ventricle is also constrained in hypertrophic cardiomyopathy, that number of the cardiac output is relatively fixed. So the index number is that cardiac output, but divided by your body surface area. So I kind of just illustrated here this concept with some numbers, and I tell patients this. If you imagine somebody who's 5'7" and has a cardiac output of 4.5 liters per minute, which I don't know if that number is normal or abnormal. It depends on how big the person is. But say that number is 4.5, and that's just a fixed number that your ventricle will pump per minute. Well, at 210 pounds, which is a BMI or body mass index in the obese range, that cardiac index is 2.09 liters per minute per meter squared. So that's the relative number. That number is low. That number is consistent with someone who has pretty severe heart failure. At 180 pounds, which is a BMI in the overweight range, that number is low normal or kind of borderline. At 150 pounds, which is a normal body mass index, that is a squarely normal index of 2.5. So with this fixed cardiac output, depending on your body weight and your body surface area, we have a vastly different assessment of how much, what your cardiac function is. So, I conclude that, some of these simple lifestyle things, perhaps, more frequent and smaller meals will help people with a lot of the postprandial symptoms, which are a real drag on patients with hypertrophic cardiomyopathy. Anecdotally, many patients will say that high carb content foods make them worse. So I encourage patients to at least explore whether cutting back on carbs is helpful. We obviously encourage patients to remain hydrated, and I kind of showed you guys why. And then, I've now gotten more aggressive in recommending weight loss, and in some cases, even with medications, which at least from other, models of cardiovascular disease are safe. But I've been more emphasizing weight loss because they do have major symptomatic and we know physiological benefits to patients. So with that, I'll conclude and take any questions.
We have a couple specific questions to the weight loss question and the overwhelming question of to carb or not to carb. Jamie's asking or stating that she recently started a diet to cut out carbs and caffeine and portion control. So she's got a 3-pronged approach. She lost 6 pounds in 2 weeks. Yay, you. But are there certain fruits and vegetables that might be more beneficial? And are there any correlations between blood sugar levels in those with HCM and their cardiac status, or is there just the general guidelines for blood sugar?
Yeah, the guidelines kind of kick us back to the, because there's nothing really specific, unfortunately, for hypertrophic cardiomyopathy. They kind of kick us back to the other guidelines for prevention and other things. So, about fruits and vegetables, I don't know. I would, a lot of the fruits, unfortunately, are high glycemic index, so they're going to kick your blood sugars up. And so, the best fruits are probably things like berries with a low glycemic index, but other wonderful fruits like watermelon and pineapple are so high glycemic, they're essentially just eating, straight sugar, unfortunately. So they're probably going to jack up your blood sugar. But there's a lot of unknowns here. We have to kind of reflect back onto, into the other general guidelines. For patients who do have diabetes, there are a number of diabetes drugs that have profound influence on weight. And in a couple of instances, and again, unfortunately, I don't see, any high quality randomized clinical trials specifically for this population coming out. But we've tried some of these, Ozempic and some of these other agents that are safe in general cardiovascular disease that are diabetes and FDA approved for other, just for weight loss indications. They can lead to profound amounts of weight loss. Unfortunately, for weight loss indications, there's not a lot of insurance coverage. So patients who do have coincidental diabetes, they can get a lot of these drugs covered by their insurance, whereas if they didn't, we wouldn't be able to necessarily afford them. So, those are kind of general ideas.
So it is a common question in the community about low carb diets. I'm one of these people who I tried it. I dropped a lot of weight. The minute I had one piece of bread, every single pound came right on back. And it's a bizarre phenomena. I would love to get some better understanding of some of the biology here as to why we have such a nasty, this is even with the new heart. It's, carbs are not my friend. So I know my experience isn't very different. So I think there's some room for research in this area. The other thing that comes up a lot of times, especially those newly diagnosed, they hear they have a heart problem and they immediately cut sodium or they cut it out completely. And sometimes that has a negative consequence. You briefly touched on it. Can you explain why average salt content in your foods is important? And for some, they may be encouraged to have a high salt diet.
Yeah, I mean, it goes back, Lisa, to what we talked about with it's the opposite of dehydration and, the the diuretic phenomenon where if your ventricle is too small and underfilled, you obstruct more. Some patients feel better when their ventricle is fuller, and so we encourage patients to stay hydrated, which obviously is challenging when sometimes people get more diastolic dysfunction, but that's kind of a more nuanced issue. But generally, we encourage people to stay hydrated. And salt, when you take salt in, your body absorbs water. And I tell people, one of your body's core key functions, it wants to keep your sodium concentration stable. And I tell people, it's like you got a perfect pitcher of Kool-Aid. It's got just the right amount of powdered sugar mix in there, and your body wants to keep it that way. And if you ingest salt, your body will absorb that much water to keep the Kool-Aid at exactly the same concentration. So that's why it's not about adjusting water, because if you take water in, your body's going to want to retain more, so it's just going to pee the rest of it out. Keeping salt is also going to keep water in there. So you want to keep your ventricle kind of plumper and filled. So staying hydrated and encouraging a reasonable amount of salt is good. And some people do, in rare instances, but you can, there's some people who would, particularly low, you don't feel as bad as you would, for example, in other forms of heart failure, to prescribe, salt tablets or other things if people's blood pressure was really, could tolerate it. But that is a common kind of misconception and a carryover from other forms of cardiovascular disease, which get confused with this thing. And I know some people have had this experience, and Shivani may be talking about it too. But some people with obstruction, when women get pregnant, actually feel some better because their ventricle is kind of hypervolemic, and so so that's paradoxical, but that seems to be the explanation for that.
One last food related question. High protein diets in HCM, this has actually come up quite a bit lately. What is the thought on, real high protein diets and their possible impact on the kidneys? And will that aggravate HCM at some point?
I don't know the answer to that. The impact of high protein diets, they will increase your nitrogen production, and then we'll measure that on your chemistries. But I don't know that they'll independently adversely affect your kidney function. And that's if you're going to eat a low carb diet, you have to eat something, and so usually people will have a high protein diet when they're on a low carb diet. So and so it shouldn't have too much of an effect. I tell people who want to do the low carb diet that because it can influence particularly for the first couple of weeks, you predominantly lose water with the low carb diet, and that's mainly because you lose a lot of fluid and glycogen in your glucose stores in your liver, so you're urinating out quite a bit, and so people do have to be careful to get not to get dehydrated for the first couple of weeks. And I do encourage them to check, a chemistry panel to make sure that all looks okay.
Meal replacements, meal bars, smoothies, Slim Fast, okay for HCM just like everybody else?
That would be a question I would have to kick to, to crowdsource here to figure out how people feel. I do think that a lot of, these things that have a bunch of sugar probably will make people feel worse. But smaller meal replacements rather than one large meal probably will help people who have significant postprandial symptoms.
And I set that question up. Thank you, Jamie, for setting it up, because now I'm going to tease. In 6 weeks, I will be joined on the podcast, Tales from the Heart, by an author by the name of Michael Moss. He has written a book. He's actually written 2 books, Sugar, Salt, Fat, How the Food Giants are Killing Us. And his latest book is available for the past couple of weeks. It's called Hooked. And it discusses processed foods and the games that the food industry is playing, understanding neuroscience and our response to specific chemicals, fat, salt, crunch, sounds. You've got to go read this book. You will eat differently for the rest of your life, if for nothing else, just to get back at the food people who literally use brain chemistry and MRIs to figure out how to make us eat more bad food. So it's really a fascinating book. And for those who have been around HCM a while and think that name Michael Moss sounds familiar, he used to be with a little publication called the Wall Street Journal. And he wrote the article about the mid-90s problems in HCM care and management that led to my sister's passing. So he's an old friend. And I think this book, it literally changed my life and the way that I eat and the way that I see food. So I encourage everybody to come along and be paranoid with me and read Michael's book. It's quite helpful. Okay, without further ado, we're going to move on to who's going next?
Shivani Patel, yeah.
Shivani. Oh, we get to talk about pregnancy. And yes, I felt better pregnant until I didn't. So tell us about pregnancy and HCM, please.
Well, thank you, Dr. Turer and Lisa, for inviting me to participate. Hopefully you guys can see my screen. So I am fortunate to work here at UT Southwestern. I'm one of the maternal fetal medicine physicians, and I get to work with Dr. Turer and Dr. Link in taking care of these patients during pregnancy. So I have that distinct privilege on a daily basis. Okay. So I'm going to start also with a case and then get into a little bit of physiology of pregnancy, and then we'll talk a little bit about how that impacts hypertrophic cardiomyopathy. So this is a patient that I took care of with Dr. Turer and Dr. Link a couple years ago. She was at the time a 31-year-old gravid of 4, para 3. So this was her her 4th pregnancy. She had 3 children. And when she came to us, she had an intrauterine pregnancy at 8 weeks and 3 days. She'd been diagnosed with hypertrophic cardiomyopathy at the age of 34. Sorry, she's 35 when she came to us, I apologize. So she was diagnosed just the year before after an episode of chest pain that took her to a local emergency room. There, she was diagnosed with hypertrophic cardiomyopathy, subsequently saw a cardiologist outside of our institution, had an ICD placed prior to pregnancy, and was placed on verapamil, and was noted to have significant left ventricular hypertrophy. When she came to us, she had actually stopped her verapamil because she did not think it was safe in pregnancy. So she came to us on no medications at all. At 21 weeks pregnant, she was admitted for episodes of chest pain, and she spent about 3 to 4 days in the hospital, was restarted on her verapamil, and we were able to titrate her up to a much lower dose than she was on previously, but nonetheless, we reinitiated her calcium channel blocker. At 24 weeks gestation, she started having significant dyspnea on exertion. So she was having significant shortness of breath with her activity, and she was started on low-dose diuretics. At 31 weeks, she was readmitted with another episode of chest pain. Fortunately, she did not bump her troponins on that admission, and we were able to get away without any medication adjustments at that admission. At 32 weeks, though, she started having increasing dyspnea on exertion and her diuretics were increased again. And at 37 weeks, she underwent an induction of labor and had a successful forceps assisted vaginal delivery with an epidural. And that labor was, induction was done with a PICC line and an arterial line in place. So when we talk about hypertrophic cardiomyopathy in pregnancy, one of the important things is to understand what are the underlying physiological changes that happen in the cardiovascular system in pregnancy. And one of the biggest things is an expansion in blood volume, and blood volume increases by 40 to 45% above the non-pregnant state during pregnancy. And that volume expansion starts happening almost immediately. In that first trimester, by 12 weeks gestation, women will have increased their blood volume by 15% already. That increase is most rapid in the mid-trimester, as you can see by the graph that's displayed there on the right hand side of the screen. And that rate then increases at a slower rate in the third trimester, peaking at 36 weeks. So it's not surprising that we saw this patient's intolerance to some of this volume expansion right around that 24-week mark, and then further at that 32-week mark. And so what's tricky here is that volume. And as Dr. Turer said, and even Lisa said she felt better pregnant, is that volume can make people feel better, but there is sort of this sweet spot where that volume can be too much for some patients. And this volume expansion happens because it's induced by the renin-angiotensinogen aldosterone system. Renin is produced in the maternal kidneys and at the placenta, and angiotensinogen is produced in the maternal and fetal livers. And this leads to that sodium and water retention that allows for this volume expansion to occur. The volume expansion is important in pregnancy because it helps meet the metabolic demands of the enlarged uterus and that hypertrophied vascular system. It provides nutrient support for this growing placenta and the fetus. It also protects against impaired venous return. So as that uterus starts to grow, it starts to compress on the pelvic vessels and that inferior vena cava. So the return is not as great during pregnancy. And so that expanded volume protects against some of that impaired return. And then it's also protective against blood loss at the time of delivery. So the average delivery, vaginal delivery, we will lose anywhere between 300 to 500 milliliters of blood. And at a C-section, losing 1,000 milliliters of blood is about average. So that expansion of blood volume is critical for that acute blood loss that we see at the time of delivery. Along with that, we see blood pressure changes in pregnancy. So that systemic vascular resistance decreases, and this is due to the vasodilatory effects of progesterone. There is thought to be some mediation by nitric oxide and then prostacyclin that's also produced in the placenta. And this decrease in systemic vascular resistance starts at about 5 weeks gestation, and it really gets to its lowest point somewhere between 14 and 24 weeks gestation. And then we'll see the slow increase back up at the end. It allows for a venous vascular bed that has increased compliance and is more sensitive to autonomic blockade. And this leads to blood pressures that decrease starting at 7 weeks gestation. Like I said, they nadir at 24 to 32 weeks. And then in that third trimester, they go back up. So as Dr. Turer alluded to earlier, that decreased vascular resistance makes it easier for the heart to contract, which means something that we have to watch for. And a lot of times that decrease in that systemic vascular resistance and that increase in that blood volume is able to compensate one for the other. So typically in pregnancy, a cardiac output increases by 40 to 45%. 50% of this increase occurs by 8 weeks. And that maximal increase occurs in the mid-trimester. The heart rate also increases in pregnancy anywhere from 5 to 15 beats per minute in the average woman. And we say, heart rates in the low 100s are not abnormal in pregnancy. And so both, using the equation of stroke volume times heart rate equals that cardiac output, we see that cardiac output increase in this really further even in the first and second stages of labor as a woman's heart rate increases during labor. The ejection fraction in a woman who does not have hypertrophic cardiomyopathy remains unchanged during pregnancy. Her left atrial volumes increase during pregnancy due to this expanded blood volume. The end diastolic and systolic dimensions are increased, and that ventricular mass increases by 30 to 35% to maintain this normal LV function that we see during pregnancy. So what happens when a woman has hypertrophic cardiomyopathy? So the pregnancy factors of an increase in stroke volume, an increase in heart rate, and this decreased systemic vascular resistance. You couple that with the factors from hypertrophic cardiomyopathy, a decreased left ventricular relaxation, a decrease in the stroke volume, and that cardiac output that's fixed, so lower than a non-pregnant, than a woman who does not have hypertrophic cardiomyopathy, puts them at an increased risk for arrhythmias and congestive heart failure during pregnancy. So it really is a balancing act in volume status. Do some women feel better and they do great with that volume, and we have to make no adjustments during pregnancy? For other women, that volume expansion can become detrimental and increase the risk for arrhythmias and congestive heart failure. Probably one of the biggest studies in the literature is actually meta-analysis of 9 different studies that was done with hypertrophic cardiomyopathy in pregnancy. It was 237 women who had 408 pregnancies. And they really found that cardiac complications complicated about 29% of those pregnancies, anywhere from 15 to 48% was that range. And the mortality rate was really low, 0.5%. In terms of fetal outcomes, the miscarriage or first trimester loss rate was about 15%, and that is no more higher than the baseline population risk. The stillbirth rate was 2%, which also is not at a higher rate than the baseline general population risk. But they did note a prematurity risk of 26%, and that is significantly higher than the baseline risk of about 10 to 12%. And a lot of that prematurity risk is not necessarily spontaneous premature labor, but rather induced or iatrogenic preterm labor, likely because of a maternal intolerance to the volume changes of pregnancy. And what they found was that those women who were symptomatic prior to pregnancy had greater adverse maternal or fetal outcomes. So when we manage hypertrophic cardiomyopathy in pregnancy, it really is a multidisciplinary approach. And I think that's where, as everyone alluded to before, centers of excellence is where I think that becomes important, is where your cardiology care and your OB care, and really having an anesthesia team that is experienced in both cardiac and OB present at one place and can collaborate and communicate. Delivery can happen through a vaginal delivery. A lot of the studies indicate that a lot of these women have cesarean deliveries, and that's not necessarily needed just for hypertrophic cardiomyopathy. And so we try to really reserve cesarean deliveries for obstetric indications only. A lot of women with hypertrophic cardiomyopathy might need an operative vaginal delivery, as our patient did. She had a forceps assisted delivery, because sometimes the Valsalva that's necessary during the pushing phase, or just a tachycardia that can be associated with that phase of labor, just is not well tolerated. And so we can sort of allow the woman to what we call labor down, meaning bring that baby down as low as we can get just with contractions, and then just have her push a little bit, or and then assist with either forceps or a vacuum. Pain control is important, not only just because it's important that she have pain control during labor, but tachycardia is what we see that with pain. And so that obviously is detrimental in the setting of hypertrophic cardiomyopathy. So regional anesthesia is not a contraindication. Women can get epidurals and get them safely. We have to dose them slowly so that we don't drop their systemic vascular resistance or their blood pressure is lower, because that is a side effect of epidurals. And it also helps us avoid, like I said, the tachycardia. So I'm going to give you guys a little bit of a prelim on some of the results that we had from our survey that we did with the Hypertrophic Cardiomyopathy Association. And thank you all for responding. The objectives was to try to understand the patient perception of the impact of pregnancy on HCM, and determine if pregnancy outcomes differed among women with a known diagnosis versus an unknown diagnosis prior to their first pregnancy. This was a web-based survey of individuals with HCM through the HCMA. And the inclusion criteria were individuals that were greater than or equal to 17 years of age. They were a member of HCMA. They had been pregnant at least once, and they had answered at least 50% of the survey questions. So we had 549 responses, and 45 of them were excluded because 17 indicated that their pregnancy number was 0, and 28 were incomplete. And of the remaining responses, 334 individuals indicated they had a diagnosis of HCM after their first pregnancy, and 170 were diagnosed before or during that first pregnancy. So when we compare the two groups, the before or the known diagnosis compared to the after or the unknown diagnosis, in terms of age and the number of pregnancies and the number of deliveries, there really was no significant difference between the two groups. Same things in terms of whether they had an obstructive, non-obstructive, or an unknown lesion. In terms of reason for diagnosis, over 50% of these individuals were diagnosed because of a family history or symptoms that they had. And 25% were diagnosed because of an arrhythmia. And arrhythmia is what led to that diagnosis, and far fewer because of an ICU admission, CHF, or need for intubation. We talk in terms of symptoms prior to pregnancy. It really was sort of equal between the two groups in terms of those that had known of their diagnosis prior to pregnancy versus those that were not diagnosed until after. Their symptoms of dizziness, syncope, chest pain, palpitations, or shortness of breath were really equal between the two, as was not having symptoms at all. Both groups had equal numbers, had no medication use prior to that first pregnancy, and 31% of women who had a known diagnosis had a history of an arrhythmia prior to pregnancy. And that sort of goes along the idea that many of the reasons people get diagnosed is because of a history of an arrhythmia. Those that did know about their diagnosis, almost 11% had an ICD placed after that first pregnancy, 6% underwent myomectomy, and in terms of pregnancy complications, the most common was a prolonged stay. About 11% of women had a stay that was beyond the normal, either 2 to 3 days for vaginal delivery or 3 to 4 days for a cesarean. And that's not uncommon because we do tend to keep these women in the hospital a couple of days longer just to watch their volume status as that natural diuresis in the postpartum period starts to occur in those initial 3 to 4 days out. And in terms of pregnancy complications, 12% of these women had a preterm birth, which is in line with the general population rate, with literature suggests, but seeing that the rate of preterm birth was higher than these other complications goes along with the literature also suggests in terms of rates of complications related to the fetus with HCM. Preterm birth seems to be higher than miscarriage, growth restriction, meaning a baby that's too small, or even NICU admission. Looking at symptoms, those that had a known diagnosis going into pregnancy, they had no difference in their symptoms before, during, or after pregnancy. So I think probably one of the keys here is that if you know what your diagnosis is, it's a little bit easier to either optimize your condition ahead of pregnancy or sort of have the proper care team around you so that you can maybe avoid some of these symptoms of palpitations, chest pain, shortness of breath, or arrhythmia. And the same thing was found in those that had an unknown diagnosis. The rates of symptoms during, before, or after pregnancy really were no different. And then we asked a question about, were you ever advised against pregnancy? And that was both either by a cardiologist, by your OB, by either, and then also we try to look at it by obstructive versus non-obstructive. And it seemed to be that those that knew about their diagnosis before they got pregnant were told by someone that they shouldn't get pregnant, versus those that were diagnosed after that first pregnancy were not told not to get pregnant subsequently. And I suspect, probably because that first pregnancy went well, if there was no reason to then say don't do it again. Versus if beforehand, I think some physicians are more likely to tell someone not to get pregnant again. And those with obstructive lesions diagnosed after pregnancy were more likely to be told not to get pregnant in the future. So this obviously was a survey, and so there are limitations. The participants are all those that are involved in HCMA, which means you guys are educated, you're involved, and you want more information, and you're trying to further the cause. And so that is a limitation because it doesn't necessarily represent the general knowledge or feelings of people who aren't as involved. There is some bias in terms of survivorship bias, recall bias, and then non-respondent bias. And that's just the nature of studies, as all studies have some bias inherent to them. But like I said, these are our prelim results. We're going to finish this analysis and then we will get to writing this paper up in the next few weeks. So I want to say thank you, and I'll take any questions.
That was the first time I got to see the data like that. That was awesome. So I turned my camera on because I was like watching.
I saw your camera turn on there, Lisa. I figured that's okay.
I'm like, I want to see, and I'm like in. So that was really interesting. I can't wait to take a deeper dive into some of that.
Yes.
I do know the survivorship issue is a problem because we have lost a few women through pregnancy, and it's a little unclear as to what led to their demise. So I think there's some value into looking at some other data points as well
Sure.
in the future. So that's really awesome. Thank you for that. So there's a question on the table related to pregnancy. And
Okay.
if your questions are still on the table, we're going to handle them at the end of the night. If your hand is raised, we're only taking verbal questions at the end of the session when we're no longer streaming on Facebook. So just put your hand down and I'll get to you at the end of the night. So the question is septal myectomy recommended before pregnancy if you have obstruction and you want to get pregnant?
Ooh, that is an excellent question. I would say I think it really depends on the degree of that obstruction and symptoms. I don't necessarily think that everyone always has to have a septal myectomy prior to pregnancy, but I would say if that is the plan or the recommendation in your ongoing care currently, then yes, probably that needs to be done before you actually get pregnant, if that is what the recommendation is coming from your cardiology team.
So I will say we've had a number of women go through this over the past 25 years or so. We've had a few obstructed people wanting to have babies, the majority of which are highly recommended to get the obstruction under control. Some of the medications, there are concerns with like Norpace in pregnancy. They're not comfortable with it.
Sure.
Typically. So you'd want to get rid of your obstruction. So if you're young and you have a high gradient, you know, you can plan this. You can think about it in advance and say, okay, I'm going to do this and give my body some time to rest and recover. And I'm going to feel good with my obstruction. And then I'm going to go have a baby. Probably a wise idea. Aslan, Mark, any comments on that one before
I
we
mean, I agree that it kind of depends on how symptomatic somebody is kind of going into it. And, you know, it's been, it's humbling to not have like, well, we've had, there's people who've flown through and it's the paradox, I think, of the gradient that some people actually do okay and their ventricle is compliant enough that they handle the volume fine and the obstruction is not as much of an issue. Paradoxically, and we kind of we'll address this, I think, in our data set, but the non-obstructive, the patients who don't have obstruction can have anecdotally had more problem. They, particularly they have diastolic dysfunction and any degree of LV dysfunction. So, we had one lady, I don't forget, who she had an EF of 50, which is not normal, but she had a septal myectomy, 10 years before or 15 or something like that. And so it was just kind of a scarred septum that had prior myectomy. And she had wicked heart failure the third trimester. She was admitted and diuresed and in the ICU for diuretics after the baby. And wow. So you never really can tell. But I've become a little scared of the kind of the stiff, real thick, small cavity kind of ventricles. And you never know with the alpha tract gradient. And then we get the question of vaginal delivery or cesarean too. And, anyway, it's a very interesting area. And you never really know how people are going to do. So I think it in large measure depends on how people are doing.
I would say it's probably the most important management outside of general cardiology for those with HCM. I mean, there's some other big surgeries that can be a problem, double knee replacement, a lot of blood loss, some abdominal surgeries. But the process of being pregnant and all those hemodynamic shifts, this is, we didn't originally, I told you HCMA recognized center of excellence are evolving. This is one of the evolutions. We want a maternal fetal medicine attachment to the program. And we want this because we've seen some bad things happen when somebody tries to care for the pregnancy at home outside of their center or not in coordination with their center. And the OB team kind of misses the importance of volume. My case was almost 6 years ago, where they thought it would be a great idea to give me an epidural, before they pushed me into a C-section that I probably didn't need, but okay, whatever. And the last numbers I heard on the table were 70 over 30. The last word I heard was, oh shit. And I crashed on the table and I almost died because they couldn't keep my blood pressure up. And I spent 3 days in intensive care after a cesarean section with an epidural that I probably didn't need, and had somebody known, it would have been better planned. I thought I was planning, but you know, it was 1995. I was not as smart as I am now. So get your care team all involved in that pregnancy decision. Most people do well. They go through swimmingly. It's not a big deal. But for some, it can be life-threatening, and we want you to be here to be a mom, and we want you to have a healthy child. So please, please, please go to high-level Center of Excellence care models for such care. Any other questions on pregnancy before we move on to our next discussion on genetics? I believe is our next talk, isn't it? Is Markey coming up next? Who's coming up next? Yep, Markey's coming up next. Yep, I have all my stuff at my home desk all set up nice, but for those of you who are joining late, Lisa had a power outage and had to come back to the office, so I'm a little scattered today. Okay, Markey, you're up, and we are going to discuss genetics. And I have heard this talk once before in person, and I am excited to see what changes have occurred in the past 3 years. It's been 3 years. Wow.
Well, thanks to everyone for inviting me back. I did speak 3 years ago, so I was surprised to get another invitation. I'm Markey McNutt. I'm a clinical geneticist here at UT Southwestern, and I'm going to talk to you a little bit about hypertrophic cardiomyopathy and how genetics plays a part in that. And if you heard my talk 3 years ago, it's pretty similar. The only thing that's really changed is I seem to have aged quite significantly in that time. So let's talk a little bit about genetics. So what is genetics? Genetics just refers to the study of our instructions. And of course, who do you call if there's a problem with understanding the instructions? You call customer service. So if Mark Link is your electrician, I am your customer service agent. So our instructions are written in an alphabet we call DNA and organized into structures called chromosomes. And every cell in our body has a complete set of those instructions. So I really think of the cell as operating like a little factory, and the chromosomes are the master blueprints. The DNA is the chemical letters that spell out each individual instruction. And we call a single instruction a gene. One gene tells the body how to make one type of protein. And the proteins, of course, are just the molecular parts that we put together to make a person. And one part of that we put together is a biological pump that we call the heart. Genetic disorders arise when there's a mistake in a gene. This can be like a single letter mistake that prevents us from making a correct version of a protein, and that ultimately leads to dysfunction. In the case of the heart, of course, stopping working correctly. So this is what our chromosomes look like under a microscope. These are particularly beautiful chromosomes because they are my own. There are 46 chromosomes in each of our cells. It's really 23 pairs. One of each pair we get from our mother, one of each pair we get from our father, so that we have 2 copies of each of them. The only exception being the 2 down here. These are the sex chromosomes. Men have an X and a Y, and women have 2 X's. So men are the exception, where they only have 22 pairs of chromosomes, and then a couple oddballs. So when we have children, we give one of each chromosome pair to our child, and our partner provides the other half. And so this is how mistakes within the DNA pass from parent to child and can lead to disease that passes from generation to generation. Now, how much information is in these chromosomes? Well, there's about 3 billion letters in all 23 chromosomes. And that encodes about 20,000 different instructions or genes. And remember, we have 2 copies of each of those genes. Except for men, we only have 1 copy of those genes on the X chromosome. Now, we don't understand what the majority of the genes do. When I gave this talk 3 years ago, there were 3,955 genes that were associated with disease, and those genes were associated with about 6,252 known genetic disorders. So you can tell from the mismatch here, there's some genes that can cause more than one type of clinical problem or disease. So what does it look like circa May 2021? Well, this is how those numbers have changed. We've gone from 3,955 to 4,434 genes that have a known disease link. And we've gone from 6,252 genetic disorders to 6,878. So we're making progress, slow and steady. Now, how do these different genes relate to hypertrophic cardiomyopathy? Well, I'm going to show you genes associated with what we call isolated hypertrophic cardiomyopathy, or having hypertrophic cardiomyopathy be really the only problem that somebody has. There are still two genes that make up the majority of cases. One is called MYH7, one is called MYBPC3. Then there are two other genes that account for about 10% of genetic cases of hypertrophic cardiomyopathy. Those are called troponin I3 and troponin T2. All of these proteins are part of what we call the sarcomere, or the structural component of the muscle. And then there is this 8% that's other. When I talked to you a few years ago, that was about 20 other genes. Currently, there are 26 other well-established genes as causing hypertrophic cardiomyopathy, in addition to the 4 major ones here. And there are 15 genes that have what we call preliminary evidence, meaning we're starting to think that they may cause hypertrophic cardiomyopathy. We're just not completely sure yet. And this doesn't even account for hypertrophic cardiomyopathy that can be part of a larger genetic disorder. So when a genetic disorder affects multiple systems, so you have a heart problem plus something else, maybe a kidney problem or a problem with the limbs, or abnormal facial features or intellectual disability or seizures, et cetera, we call that a syndrome. And there are dozens of other genetic disorders that can have as one of their features hypertrophic cardiomyopathy. But I'm mainly going to be talking about the ones that are associated with just hypertrophic cardiomyopathy. So these 30 genes. And so if we look at just those 30 genes in patients who have cardiomyopathy, how often do we find a clear genetic cause? Well, it really depends on whether you have a history or if there's only one person in your family affected. If there are multiple members in your family who are affected, we find a clear genetic cause about 60% of the time. And if you don't have a family history, we find the cause about 30% of the time. So even though we've learned about a few more genes, that's really only added a few percentage in here. And so the numbers overall haven't changed. And so you can see we still have a lot to learn. So the majority of isolated hypertrophic cardiomyopathy is inherited in what we call a dominant manner. Most of us have heard about dominant and recessive traits, and most of these are dominant. So what that means is that with each generation, there's a 50% chance of that disease being passed on. The reason for that is that we have 2 copies of each gene, and dominant inherited diseases require a mistake in only one of those 2 copies in order to cause disease. And so if you have a mistake in MYH7, for example, you only need a mistake in one of the 2 copies. And so if you're affected here in blue with hypertrophic cardiomyopathy, each time you have a child, you'll give one of the 2 chromosomes to that child. And which one you give is really random. So it's like flipping a coin each time. So there's a 50% chance that a child will inherit that abnormal gene and have hypertrophic cardiomyopathy. There's a 50% chance that they'll inherit the normal copy and not have hypertrophic cardiomyopathy. Now, if you inherit the disorder, you have the possibility to pass it on to 50% of your children. If you don't inherit it, you cannot pass it on because you don't have that mistake to pass on. And so what we see is families that look like this. We draw families with men as squares, women as circles, and each level of this is one generation of a family. So you see grandparents here, their children and their grandchildren. And on average, about half of each generation is affected. And again, if you don't inherit it, you can't pass it on. If you do, you pass it on to about 50% of your children. And again, these are independent risks. So it doesn't matter how many children you've had before that either have the disease or don't. each time you have another child, it's truly 50-50 each time. So how do we test for these? Well, there's two different types of testing that we do in genetics. One is what we call targeted testing. That's what we do if we know what the genetic change is in your family, meaning somebody else has already been tested. We know what's running in the family. In that case, we can look just for that genetic change that we know that's present in your family. Doing so, we can give you basically 100% accurate result of whether you are positive, meaning you inherited genetic HCM, or you're negative, meaning you did not inherit it. But what if we don't know what the cause is in your family? Maybe you're the first person affected, or maybe nobody was tested previously. In that case, we have to do something called panel testing. That's basically where we have a list of those 30 genes that we know are associated with hypertrophic cardiomyopathy, and we go through each one of them, and we spell check each one. In doing so, it's a little bit more complicated. We can actually get 3 different results. We can either get a positive or negative, like we can in targeted testing, but we can also get something called a variant of uncertain significance. That's a misspelling in a gene that we can't yet interpret because we don't have enough information. And we see that in about 30% of cases when we do these panels that have multiple genes. Doesn't mean you have a disease. It just means you have a difference that we haven't yet been able to classify. So what does testing look like if you wanted to get testing? Well, the first step is really to meet with a genetic counselor, geneticist like myself. The reason for that is we need to find out what the right test for you is. It may be that testing for isolated hypertrophic cardiomyopathy genes is the right thing to test for. If you have other clinical features, it may represent a larger genetic syndrome, and we may need to do a different type of test that includes other genes associated with those disorders. Additionally, we want to make sure you understand the potential risks of testing. So one thing that some people don't think about is that a genetic diagnosis can have effects on insurability and things like life insurance, long-term care, and disability insurance. And so we want you to understand those risks prior to doing testing and not once the cat's already out of the bag, as it were. So when I talked to you 3 years ago, I said the next step if you do testing is to get blood. Nowadays, it's really been proven that saliva is just as good and easier to collect. We can send you a kit right to your home. You can provide that saliva sample and send it back into the lab. Once the lab has it, it takes about 2 weeks and we get that result. So we always paint kind of a black and white picture of the genetic testing, and you either have a positive result or negative result. As I said, it's not always that clear. Sometimes we get an uncertain. And even if we find out you have one of these genetic disorders, unfortunately, genetics is not a crystal ball. We can't tell you exactly what's going to happen to you. The reason for that is due to 2 features of genetic diseases. One is what we call variable penetrance. I think of this like the genetic time bomb. If you inherited that genetic change, you basically inherited a genetic time bomb. We don't know if it will actually go off or not during your lifetime. And with cardiomyopathy, that's age dependent. The older you get, the more likely you are to have disease related to that gene. Now, the longer you go without having it, that's great. Once you get up, 70s, 80s, and haven't had any symptoms of the disease, you may not have them during your lifetime. Now, it's only a small percentage of people that don't have any symptoms, but it does occur. The other feature is what we call variable expressivity. I like to make the metaphor to birthday cake. So if you and other family members have a specific genetic change, it's basically like you all got a slice of the same birthday cake. The problem is we don't know how big that slice is. So some people within a family will have different age of onset, different initial symptom, different severity of that symptom, and different progression of their symptoms. And we actually can't predict that from the genetics. It's just kind of a wait and see. So why would you want to test? Obviously, to find a specific diagnosis and what we know about the prognosis with that specific genetic disorder. It will allow us to test family members and see who else is at risk for hypertrophic cardiomyopathy so they can be followed more closely and treated as early as possible. In the future, there may be gene-specific therapies. And so knowing what genetic problem you have may be important for specific treatment. It's also important for participation in clinical trials for these therapies. The limitations, as I said, may not change treatment right now. You may have an ambiguous result that we can't yet interpret. There are still gaps in our knowledge, as I said, and genetic testing is not a crystal ball. It's not going to tell you what's definitely going to happen to you or not in the future. And as I said, testing can affect insurability, so it's good to talk to somebody prior to testing. Now, I want to be very clear that cost should not stand in the way. In the past, genetic testing was very expensive. Today, you can get free testing. So keep that in mind. This should not be a roadblock to you getting testing for you or a family member who may be at risk. We're here to help if you need testing. Again, I do recommend you talk to a genetic counselor, geneticist before you do the test, and that can have a cost associated with it, but there are ways to minimize that. You can get telehealth genetic counseling for as low as $125 from some providers. And in many cases, your insurance will at least cover you talking to a geneticist or genetic counselor. And then the testing part, again, is free. So that's all I have for you today. Thanks for your attention, and I will take any questions.
So yay, yes, you're right. You don't have to worry about cost anymore. There are a number of sponsored tests. I want to take a moment to explain that because some people get concerned when things are free because there's no free lunch. I want to explain very clearly that these drug companies sponsored genetic tests are safe and private. That's number one. So why would they do free genetic testing? Because HCM is kind of the gateway for a lot of other disorders that look like HCM but have a very different genetic basis. Fabry's disease, Danon's disease, excuse me, amyloidosis. So they have their own therapeutic pathways and they're very hard patients to find. So if somebody does genetic testing for HCM and it comes up to be one of our spectrum disorders, something that looks like HCM but is a very different genetic basis, that test will trigger the lab to call the doctor who ordered your test to say, hey, this is one of the spectrum disorders, and we want to make sure that you're aware of this because it's really rare, and we want you to know that there's a therapy for it. So the price of a free test is that if it's something rare, they're going to contact your doctor and say, hey, there's a therapy for that. It's a win-win for everybody. Invitae has been doing this for about 2 years now. You can get the information on our current HCMA website. I'm not sure where it's going to be located. I think it's going to be in the resource tab on the news site coming up very, very soon. But I just want everybody to know, you literally, if you have a diagnosis of HCM, go take a couple clicks, talk to a genetic counselor, always a great idea, and you can get a free kit. And it's really easy right now. I don't want anybody, I don't know why, and Markey, help me with this one. Why is this a blood chemistry panel seen so differently than a genetic test? It's just an analysis of your personal material. Why do people get so afraid of genetic testing, and how can we encourage them to use this amazing technology?
I think there's some concerns about misuse of genetic information. It is protected like any other health information, except it is more predictive than a regular lab test, tells you what things look like right now. A genetic test may predict what things look like in the future. And as I said, right now, life insurers, long-term care, and disability insurers can use that information to deny you coverage. And that's something that they may not be as strict about with just a regular blood test. So I think some of that is warranted. Additionally, we don't have good legislative safeguards in place for genetic information yet, especially related to how genetic information is used, because it is uniquely identifiable, right? So there's no way to de-identify genetic information. It can be traced back to you specifically, even if we take your name off of it and everything. And so there needs to be safeguards there from a societal perspective that just aren't there. So I think some reluctance is warranted, but in a case where it has such a major impact, like in this case with hypertrophic cardiomyopathy, if you have a personal or family history, those risks are outweighed by benefit of knowing the answer.
I agree. So Jamie's asking another great question. And her question is a little bit long, so I'm going to shorten it up a little bit. And the question is, so she has 2 children. One is gene positive, one is not. She's been genetically screened as the carrier. But her other daughter, who's not affected, is having symptoms that look like HCM type symptoms. And they assured her it has different, a different etiology. It looks like hyperactive thyroid and anemia. But she's wondering, did they find all of the mutations in her genetic test 7 years ago? Could she possibly have a newer mutation that maybe her one daughter only has 1 mutation and the other daughter may have a different mutation? Is it worth it to go take a deeper dive into genetics after 7 years?
That's a great question. I would recommend that your daughter be evaluated independently. So if she was just tested for the specific variant that was identified for you, I don't know. She may warrant additional testing at this point. That is a good question about, can you have 2 things? You can, but it's very rare. So it's less than 1% of patients that have more than 1 pathogenic or disease-causing mutation in HCM genes on testing. And so while it is rare, it can happen. So I'm not going to say it's impossible. And that's why I say if there's any concern, your daughter should be independently evaluated to see if she warrants additional testing for other genetic causes.
Good answer. I agree. Aslan, you coming back on with us? Turn on the camera. Unmute your mic. Did you want to introduce our other person here today before we go to
Yes.
Q&A?
So let me just say, and many people already know that I came down with an uncommon form of cancer, which I am currently getting treatment for, and which I hope to still have many years to live with. But coincidentally, we got a new faculty member from the Mayo Clinic who has obviously an extensive training background in hypertrophic cardiomyopathy and in heart failure, and he had expressed an interest in doing hypertrophic cardiomyopathy, and the timing kind of just worked out that we would bring Dr. Wan on board to help with our growing number of HCM patients. So while I personally am still in clinic, 3 or 4 days a week, I wanted to make sure that we had continuity of care for years to come. So I wanted to introduce and bring on Dr. Wan, and he could just say a few words, and then so he's a familiar face to everybody at our center.
Yeah, thank you very much for that introduction, Dr. Turer. So again, very briefly, I'm Seung-Hoon Won. My interest and background is in heart failure as well as echocardiography. And I'm relatively new to Dallas as well as UT Southwestern. I'll keep my comments brief, but I just, there are 3 groups of people that I want to thank. First of all, Drs. Aslan, Turer, and Mark Link. Tremendous clinicians and thought leaders in the field of hypertrophic cardiomyopathy. I'm very honored to be invited to work with them. And I very much look forward to working with them and learning from them. They've really built a heart team for hypertrophic cardiomyopathy here at UT Southwestern and developed a center of excellence in North Texas. And they are truly to be congratulated for their incredible contributions. Second, I'd like to thank Lisa Salberg for inviting me here to this panel today. She is one of the most passionate people I've ever met, and with the Hypertrophic Cardiomyopathy Association is an incredible advocate for patients. So I'm very honored to work with her and very excited to be a part of this group. Finally, I wish to thank all the attendees. This is a very complex condition, hypertrophic cardiomyopathy, and it really requires detailed patient-physician discussions. We've heard about patient-centered decision-making earlier today. And thank you to everyone for attending and just acquiring as much information as possible. Knowledge really is power in this situation. So thank you for your time and spending your time with us this evening. I'm very much looking forward to working with the Hypertrophic Cardiomyopathy Association, working with Lisa, Drs. Aslan, Turer, and Mark Link, and the entire team, both at HCMA and UT Southwestern, to really deliver the best patient care, advance the science of hypertrophic cardiomyopathy, and sharing our expertise with patients as well as the next generation. So thank you very much.
Thank you and welcome to the family. Aslan, I have a comment for you. Getting your email with your news of your diagnosis was staggering, and my heart broke for you. Even though it's a replacement part, it still can break. But I want to share a thought with you. And I know it's a complex diagnosis and it's not the same as transplant, but I know because other researchers in other fields have given the same dedication and passion to trying to cure your disorder as has given to the HCM community to try to solve our problem. I am hoping that science and a little bit of luck and a lot of positive attitude give you the best possible outcome and the best quality of life for as long as possible. And we're here to support you during your journey.
Well, I really appreciate that. And, we talked before, but it's been an eye-opening experience to be on the other side of the, I don't know what you'd say, bed sheet or something. Yeah. It's, from getting the diagnosis to getting genetic testing on my tumor to, having to take advice from doctors that I normally avoid doctors, and then taking medicines, and there's been a lot of familiarity with what I've had to do, and it's changed me as a person and as a doctor, I think. So I think I have a lot of advocates for me, and I'm hoping that we can get some good response and chop things out and whatever else I need to get done. But I hope to be active in this community for a long time still. But it's really changed me, I think, as a person and as a doctor in a very short period of time. I mean, this has all transpired in the last 2 months, but it's been an amazing kind of gift to see this all.
Well, I know we have some work to do. We have some articles to write. So, you got to get shit done. So you got to stay well. And we're hoping that stays a long time. So I'm going to pivot the conversation back to our Q&A. So I don't get all upset here and start giving the rah-rah speeches on how to be sick and how to get well. We do that all day here. So some questions and some comments, and I'm going to put them in order. And I'm reading them exactly as they appear. Dr. Link, you are a class act. Thank you for your expertise. Boston misses you. So when Mark told me he was leaving Boston, I'm like, why? Where are you going? And he said, I'm going to Dallas. I'm like, okay, I need you there too. And I don't feel like the HCM community lost anything, but I do think some of his patients feel like they lost something. So they still miss you up there. So that's that. So whoever typed that in, thank you, because now I got to, embarrass Mark a little bit.
No, I miss many of my patients in Boston. The HCM community there was and is wonderful.
I agree. COVID question. I am COVID vaccinated. I hope all of you are COVID vaccinated. Have you noticed post-vaccine temporary large rise in BNP? And I will add to that, have you seen any arrhythmic consequence of vaccination? Aslan?
Yeah, I haven't seen that, but there have been a couple of cases, of COVID vaccine associated pneumonitis or inflammation in the lungs, and myocarditis, which obviously we think of getting when you get COVID infection. But in fact, we had a faculty member here who got his COVID vaccine and then develops myocarditis afterward. And so I suppose it could be related to that, and the symptoms of myocarditis can be, pretty fulminant, or in these other cases, they weren't that dramatic and probably fairly in line with what people with hypertrophic cardiomyopathy might feel on a day-to-day variability basis. So I suppose it's possible that it's related to the COVID vaccine, but the NT-proBNP can vary itself quite a bit depending on your volume status. And I don't know kind of how yours normally runs, but long and the short of it is it could be related. We have seen some cases of cardiac inflammation related to the vaccine. They've been reported worldwide. It's not very common, but it's possibly related to that.
So in terms of arrhythmias,
Yes.
certainly people who get COVID have a risk of myocarditis, and that can affect both the atrium and the ventricle. So we have seen predominantly an increase in atrial arrhythmias with COVID, not with the vaccine. And but the risk is not great. We thought the myocarditis risk was much higher earlier on in the pandemic. It's not nearly as high as we thought. And I've never heard of any trouble with the vaccine and specific arrhythmias. So I've not heard of that.
Nor have I, but I get questioned on it all the time. So thanks for addressing. Another question, we're going to go back to lifestyle type issues. Is there a particular type of exercise that you recommend for those with HCM? How do you lose weight, build muscle, stay healthy, and not decompensate yourself because you get dehydrated because you're not keeping your hydration properly? How do we balance all the things to be as awesome as we can be?
Yeah, I mean, exercise in hypertrophic cardiomyopathy is the 14-hour talk.
You should have brought Ben. Where's Ben?
Yeah. In general, I tell, I think we've gone full circle, I think, from extremely restrictive to far less restrictive. And, we're doing a study here in terms of high intensity exercise. So we know from studies at moderate levels of, moderate intensity exercises seems to be safe, at least over the short term. And like I said, we're with Dr. Levine and Dr. Link looking at a high intensity exercise. We haven't seen much in the way of, any worrisome signals there so far, but, in other words, we're looking at pushing the bounds in terms of, activity. I this is just me, I suppose. I usually discourage people from doing a lot of, kind of CrossFit kind of activities. And I still recommend avoiding a lot of heavy weightlifting where bearing down is an issue, and Valsalva maneuver, just because in patients who are obstructive. But I think, you really want to at least encourage moderate levels of activity where you're feeling winded with that activity. And, you can look at Borg scales and, somewhere in the, 12, 14 range probably is where you ideally kind of want to be in pushing your levels of activity. Heart rates, we frequently get that kind of question. That level of moderate activity is probably somewhere south of 70%. I think the guidelines suggest something like that. So in terms of specific activities, I think in general, doing exercise is incredibly important for patients to ward off like a lot of other metabolic conditions and just to feel good and to have a better functional capacity. Whether, will 30 minutes of exercise a day for several, a few days a week, will that result in appreciable amounts of weight loss? Probably not as much as we would hope. I mean, I think a lot of that's going to be dietary, but there's so many other, health benefits to doing exercise. People have to go to the gym for a long time, I think, to actively lose weight by working out. But I just encourage people to do the kind of the activities that they want to do with certain limitations in terms of weightlifting and other things. I don't know, Lisa, what do you recommend to patients? This come up all the time when patients
Walk, walk, move. If God made the food, eat it. If man messed with it, leave it alone. Those are my basic diet tips, with one little exception. A little bit of chocolate's always a good thing.
I'll add my 2 cents about exercise too. I have 2 kind of rules I tell my patient. One, find something you like to do so that you keep on doing it. Because the worst thing you can do is start spinning and you hate it, and then you're going to quit exercising. So find what you like to do. And I think a walk, a good brisk walk is a good form of exercise. And the second rule is, in terms of intensity, you should be able to converse with the person next to you, even if you're walking alone or running alone. And if you're ever at such a state that you can't talk, that's too intense. And those are my 2 general rules.
And if you're exercising alone or walking alone and nobody can actually hear you, you can sing when you walk. And if you can't sing, then you can't walk. So those are some good tips. Simple things that, I've picked up over the years that actually work. Shop on the outside of the store. Don't go down the aisles in the middle. That's where all the processed stuff is. Very, very simple. And watch your portions. These are the things that really work long-term. You can't eat massive portions of it, pretty much anything other than like maybe mushrooms and some vegetables, but you can't eat big portions. It's just not good for your HCM heart, and you don't feel well. And then you want to sit on the couch, and you're on the couch too long, and it's this bad cycle. Get up and move. If you're feeling a little depressed, join a discussion group, support group, talk it out, get out of your head, get out there and live your life. You may not be able to walk with the friends down the street who do speed walking every day, but you can get out and move. You can do 5-pound weights, keep the muscles toned, and keep with it. And Fitbit, Apple Watch, track yourself. If you're doing 5,000 steps a day, have a goal to add 500 steps that week to your step count and slowly build yourself up. It works. I used it after transplant to kind of rebuild myself. Started at 5,000, slowly got myself back up to 10,000 steps a day plus. And it happens slowly. Be patient. Be patient. 3 years ago, somebody had genetic testing, and there were 2 VUSs found. Where do they go to get updated information on their VUS? How do they know what it really means today?
That's a great question and not a simple answer. So VUSs tend to be relooked at by labs when they see them again. So if they haven't seen it again, they've probably not readdressed it. And different labs have different policies. Some of them will reissue reports after they have reclassified, and some will not. And so it depends on what lab did your testing and who did your testing. So if you had a geneticist or genetic counselor that you worked with, you can always get back in touch with them and ask them to look back at the variants. If it was done through somebody else, you just have the test. You can also call the lab that did the test, ask to speak with a genetic counselor about your results, and they can take a look at it. I do recommend that you check back in on your variants every 1 to 2 years to see if they've been reclassified.
There is a project that I've actually been involved with. This is year 3. It's Wendy Chung at Columbia and a bunch of other people in the know of genetics, specific cardiogenetics. And under an NIH grant, there is this massive evaluation of what to do with classifications of genetic mutations when they change. When I said, sure, I'll be a part of this project as the voice of the patient, I thought this was going to be an easy one. Then you realize the ethical implications. When does a relationship start? When does it end? With a laboratory, with a physician? Is there the expectation of a doctor-patient relationship a year later, 8 years later, 20 years later, 40 years later, who is responsible for that transaction? And when you start to build the logistics model in of redundancies that might be needed, your brain explodes and you go, I don't know the answer to this one. And smarter people need to come into the room. So a bunch of smart people have been in the room twice and have gone back into working groups. And we all go back to the room in a couple of weeks to revisit what we've determined based on a whole bunch of different analysis. And then there'll be recommendations made on who's got responsibilities where. So the industry has a responsibility. Where does it start? Where does it end? Physician, healthcare system, patient. Is it my responsibility to keep coming back and asking you? I think that's part of it. Is it the physician's responsibility to tell you when they find something out? Yes, but where is the effort to make them go back and find it out? There's a lot of questions here. We're in evolving times. Thank God we're in evolving times. I've even heard tell that there's some new technology out there that may be using mRNA vaccinations to correct some mutations. We are in a whole new world, people. So stay in touch, ask good questions, follow up. We're actually creating some tools here at the HCMA so that you can keep your records organized and remember to ask every few years about these types of things. So we're trying to help make it easier, but it's definitely not easy. And I do have to say that there's a question came from somebody in this room today that has a very interesting tie to the history of the HCMA. And I wonder if this person remembers it or not. In about 1993, his mother and my sister shared a hospital room in the cardiac wing at Morristown. And they were both shocked because neither of them had ever met anybody outside of their own family that had HCM. So it turned into a mini support group meeting in the hospital room. And then I walked in, and my sister and I had decided maybe someday we ought to start a support group for patients with HCM. Unfortunately, my sister never got to see that happen, but she's behind all of this. And I hope the person who's posting remembers that story, because I don't want to out the mom who is since passed, but it's nice to see your name again. Okay, anonymous. Role of slight anemia in HCM. Why do patients with HCM seem to have a little bit of anemia all the time?
You know, I don't know the answer to that. It's often seen with forms of heart failure that patients will get anemic. What exactly the cause is for that, I'm not really sure. Anemia will drive increases in flow across the outflow tract, so they will confound or worsen, or at least confuse the interpretation of outflow tract gradients. People who are significantly anemic, their hearts are hypercontractile, they're pumping quite a bit, and you can actually develop artificially outflow tract obstruction, or in the case of people who have some element of aortic stenosis, they'll actually look like they have severe aortic stenosis from anemia. So we do know that there's a relationship between outflow tract gradients and anemia. What the relationship is between some slight degree of anemia and hypertrophic cardiomyopathy, I don't know. I don't know if anybody else on the panel knows.
Anybody else have any comment on that?
Lisa, have you seen anemia frequently?
Always low grade anemia. I've had family members with HCM and anemia. There was never a really strong why for me, other than possibly the fact that the cavity's smaller, so there's just less blood volume. All you gotta do is get pregnant, and that fixes that problem.
But anemia is an incredibly common diagnosis too, especially among, menstruating females. So there's got to be a lot of overlap there too.
Always borderline anemic as a kid, teenager. And I kind of just ignored it, to be honest with you. I didn't, it was just my normal. So again, just what you learn to live with, you don't know what normal really is until you're not anemic anymore. So I don't know that we have a good answer. Maybe we have a good research question. Why are patients with HCM anemic? We will also be answering another interesting question. Why do HCM patients tend to have a lot more migraines than others? We're about to do a survey on that and see if we can find some correlation there with the type of migraine and the frequency pre and post myectomy as well. So we have a really cool survey about to come out on that. So stay tuned. All right. Sorry, anemia questioner. I don't have a good answer for you, but we tried. Okay. So we're back into the girl category again, but this is a little different. Chest pain. The commenter is stating that she cannot wear a bra because she has pain every time she wears a bra, and she hasn't had myectomy or surgery in the area. She doesn't understand why this pain occurs when she's wearing a bra. First question is it a properly fitting bra? Is it too tight? Is it restricting your breathing? That's a simple question. Beyond that, I don't have any really good answers to this one. Does anybody else?
I haven't seen that before. It doesn't sound like you've heard of that.
Okay. It's getting late. It's summer. I'm COVIDed out. Most women prefer not to wear a bra. It's more comfortable that way. And the women are going, yeah, but we gotta. So some people just find them uncomfortable in general. But if it's pain, that wouldn't make any sense to me from an HCM point of view, because the mechanisms of chest pain in HCM would be microvascular disease, the little teeny vessels inside of your heart are getting clamped down and not getting good oxygen, causing chest pain, or obstruction. So if you don't have obstruction and you don't have microvascular disease, chest pain is not really that common in HCM. So what do you guys think?
It's hard to directly attribute to the HCM.
Yeah. Okay, so we normally like nail all these questions and let people go, oh my goodness, I got all the answers I need. We got a couple that we just can't answer tonight.
These are the patients I sent to Aslan. I said, I can't figure this out. It's time for you to see Dr. Turer.
Yeah. And then sometimes Aslan says, why don't you call these?
Yeah, that's my backup now.
Yeah. Okay. Exercise. And this is the last question on here. Once we're done with this question, we're going to stop Facebook feed and then we'll do the hand raising thing and you can say whatever you want to say. Regarding exercise, about using an upper body ergometer. I don't know what that is.
I think it's like a cycle sort of.
It's like the little pedally thing. Yeah.
With resistance.
Okay. What do you think?
I think it would be fine to build upper body strength. I mean, I don't think it would cause, I mean, it's nice to get out and move, I think, but, you know, I think that would be well tolerated in terms of activity and building upper body strength. There is, you know, and I don't know, in Mayo, I don't know, Suhan, did you guys had experience with this, but, you know, I think positional exercises, some exercises tend to be tolerated better than others. I have a patient who, he's an avid triker. It's like a bike, recumbent bike. It's about 3 wheels. And he will ride that thing 50 miles every Saturday. But when he went up to, he was in Hawaii with his wife and they were like hiking up one of these volcanoes. And he's like, I was extremely, you know, dyspneic. And he has significant obstruction. So it's interesting because I think the recumbent exercise with biking, he tolerates that from a blood flow back to the heart, maybe less obstruction standpoint than he does doing what you would think would be less activity, hiking, you know, on a trail. So some of these exercises, you know, I tell people, you know, they're going to tolerate some things better than others. Stairs are notoriously difficult for people with hypertrophic cardiomyopathy.
I actually like yoga and Pilates. They both work really well. And the Pilates, you get a little bit more resistance. You can't do every single moves, and they do some inverted type moves that those are the fancy girls. We don't do that one. We do the basic stuff. So I would keep an eye on that. Okay, to those who are viewing on Facebook, thank you for joining us this evening or watching it whenever you're watching it. This will be pushed over to our YouTube channel soon. Subscribe to us on YouTube, like us on Facebook, follow us on Twitter, join us on LinkedIn. For the professionals out there, we have a HCM group on LinkedIn. So if you're not in, go be in. That's a whole international cohort we got there. So I thank you all on Facebook, and we're saying goodbye to Facebook.